To reach out to our friend Santa and see what kind of jokes Santa might be able to provide. So, again, not ran by my daughter, but also this one came from Santa Claus. So if you have a problem, write a letter to the North Pole and let him know. How much does Santa pay to park? Nothing. It's on the house. I thought that was good. Those of you that groaned, shame on you. I thought that was good. You're now on the naughty list, by the way, because I'll point out you just groaned at Santa's joke. So, you know, straight to the naughty list.
That was good, Andy.
That's your best one right there. That's tough.
Year-end special. Santa special.
We're very excited about our speaker today. Our speaker is, actually, I'll let you introduce him. Well, don't you have a bio on him?
No.
No, you don't?
No, but
I thought you did.
No,
Oh.
I don't think that. Joey, come on up.
Come on up.
I'll
You
wing
know
this.
this.
Joey Peay. He has been affiliated with Murfreesboro Medical Center. How many years?
27 and a half.
27 as CEO and now as CFO. Is that correct?
Other way.
CFO and now as CEO. So I've tasked him, you know, I always put a name on these presentations, and so I think I said challenges of healthcare delivery. But I tell him he can take that wherever he wants to. So please welcome Joey Peay.
All right.
Let me get your.
That's all.
We get switched over. Andrew was saying the corny joke, and like, okay, that's actually a decent joke, and waiting for all the groans and things. But as Roy said, I'm Joey Peay. I'm CEO at Murfreesboro Medical Clinic. I've been in that role for since 2003. I'm an accountant by training. I spent 10 years after graduating from MTSU with one of the world's largest public accounting firms in Nashville. You may have heard of KPMG. But I'm also one of the weirdos that actually grew up here in Murfreesboro. Lived here all my life. My wife and I still live on a Revolutionary War land grant farm out in the Reedsville area, where I use my gig at MMC to finance a bee farming habit. So a little cold putting out hay this morning. So you can get into this. This is our main location. Y'all may be familiar with. We moved into the north end of that in 2008. We moved into the south end in 2013. It's about 225,000 square feet is our main location. Y'all know about MMC. It's founded in 1949 by Dr. Carl Adams and Dr. S.C. Garrison, a general surgeon and an internist, that really introduced multi-specialty medical practice to Murfreesboro and Rutherford County. We currently have 8 locations, 7 of them in Rutherford County, 1 down in Coffee County, a little small office down there. Approximately 110 physicians in 21 different specialties. To give you some idea of the scope, in 1998 when I joined the clinic, we had 49 docs. Over the next 3 years, that number fell to 37. That doesn't mean we lost, 12 docs? It means we lost 20 and gained 8. That was a very difficult, tumultuous time in the clinic's history. But we've now have 95 advanced practice providers. These are nurse practitioners, PAs, CRNAs, audiologists, other licensed medical professionals that provide care. We don't call them mid-levels anymore. It's all about advanced practice providers. But 985 I saw on a different slide this morning, so they didn't tell me about the last 5 people we fired. But growing, again in 98 we had 6 nurse practitioners as part of our practice, and over the last 27 years we've gotten that almost to 100. Overall, we're almost 200 providers right at that number. Our primary service area is the southeastern quadrant of Middle Tennessee. I kind of highlighted it as best I could, encircling it in blue, but you can see that all the way down to the Tennessee state line, pretty much the Monteagle Mountain range coming up, but then picking up Warren, DeKalb, and Cannon. We might get a few people from southern Wilson County. We're getting some of these from the eastern edge of Williamson County with the new office we have out off of Veterans Parkway. But it's pretty much the southeastern quadrant of Middle Tennessee. couple other things about MMC that you may or may not know. We have 2 ambulatory surgery centers. We opened one in 2023. It is a single specialty GI facility, again, out off of Veterans Parkway on Shores Road. We have the one that's been at our, it's been open since 1990. When we moved to our new location off of Highland out to Garrison Drive. It is now a six room OR, 6 ORs, multi-specialty where ophthalmology, ENT, pretty much any of our surgeons can use that facility. We have full service imaging at 2 locations. We have 2 smaller imaging centers at our smaller offices, one on South Church, and then the office we've got going in on Las Casas Highway out in that one. So I'm actually already counting it in that, but this time next year it will be operational. It should open probably this summer, May, something like that. We have very high complexity lab services that we offer. We do more lab tests than a lot of hospitals, especially some of the smaller ones, but several 100,000 laboratory tests that we do every year. We've got 4 retail walk-in clinics. The first one was out at Las Casas at Rutherford Boulevard in the Kroger Shopping Center. We've got a couple of those. These are not urgent care centers. That's a different animal within the healthcare field. I call them just retail walk-in clinics, but definitely not urgent care. We offer infusion services. We're doing clinical research now, and then we also have a specialty pharmacy that is in the works that will be opening very, very soon. So, when Roy was saying about kind of the challenges of healthcare, and then I heard these 4 pillars over here, the 4-way test, and it's like, okay, can I complete this presentation and meet all of those? It might be a challenge, but I'll do my best. So when you think about at a macroeconomic level, basically what's challenging us, and having Gordon back there for I guess 27 years in this market as well, I think he can probably echo some of these and or look at me askance and say, Joey, what are we talking about? But here's the first one. As MMC, we have 3 very large active health systems active in Rutherford County. 3 of them. So many places only have 1 hospital system that they've got to deal with. We have to navigate 3. When you consider the role that Ascension plays and has played for a number of years, 15 years ago, 20 years ago, when HCA, the largest, I guess, for-profit healthcare system, opens up a hospital in the Smyrna area, what does that mean for us? And then you've always had some type of a role that Vanderbilt's tried to play, whether it be some of their physicians down here. They have a couple offices. They've got that new facility across Garrison Drive from us, and the hospital that is still potentially in the works. I'll go ahead and tell you what I know about that, because before you ask me, there was a hearing on March 19th in Chancery Court in Davidson County about the provision or the allowance of the CON for Vanderbilt to build the hospital. It was originally expected to take 90 days for a decision. That would have been June 19th. And here we are on December 16th, 270 days later, and we still don't have a decision. So that's where that stands, and whether or not Vanderbilt's going to be able to get the CON to build a hospital in Rutherford County. But navigating that, and as I've kind of described it to our board, is all 3 of those systems want to date us. And we want to date all of them. So it's a fine line that we have to do to have a good relationship with Ascension, have a good relationship with Vanderbilt, and a good relationship with HCA, because at the end of the day, our goal is to take care of patients. And we want to provide the patients the choice that if they want to go to Rutherford, we send them to Rutherford. If they want to go to TriStar or Stonecrest in Smyrna, we can send them there, and if Vanderbilt gets a hospital here, or for that matter, we send quite a few patients directly to Vanderbilt, especially on the pediatric side. But that's kind of what we're faced with, is just a challenge here in the county. Now, I'll also say that's a blessing for the folks in the county, because you do have a number of choices when you're seeking health care. We're the largest provider group in the community. So we've been talking to some other groups around the country. What I've found, and even in the state of Tennessee, there's a clinic like ours in Nashville called Heritage. There's a clinic like ours in Jackson, and a few others around the state. And when it's really said and done, MMC's on the smaller end of some of those. There's some larger groups up in East Tennessee that I guess one, and this is where I may struggle a little bit about, is it fair to United Healthcare to, there's a challenge in the country right now that, talking to Tom Wallahan over there, former independent physician that's now retired, 77% of the physicians in this country are employed now by hospitals, health systems, insurance companies, and private equity firms. 77%. That means less than 1/4 of physicians in this country are still independent. Less than 25%. And when you consider United Healthcare is the largest insurance company in the world, they employ 10% of the physicians in this country. 90,000 doctors and growing are employed by United Healthcare. I look at that and say that's not a good model for patient care and what really needs to be done on the healthcare side. That may get into the next slide with the macroeconomic issues. But MMC is an independent physician group. We're owned by the doctors that are practicing there. I've got a few that aren't shareholders yet, but they're all on a shareholder track case to where they're ultimately going to buy in and become shareholders and owners. How many of you have gotten a letter from me in the last few months about a physician of yours that is not coming back after a maternity leave or is retiring or something like that? So that is a challenge. When you talk to the Chamber of Commerce, 25 people a day are moving to Rutherford County. So every 100 days, basically every 3 months, that's 2,500 people. I hope one of those is a primary care doc, because that's a practice moving to Murfreesboro every 3 months. So I got a letter this morning from a patient that her physician, she got a letter from me, her physician's not coming back from maternity leave. And she got assigned a new doctor who is currently on maternity leave. And I think internal family medicine right now has either 4 or 5 physicians either pregnant or on maternity leave. Well, you take a young lady going through medical school, she's got 4 years undergrad, 4 years medical school, and just say a minimum of 3 years residency, maybe a 4th year in fellowship. She's approaching 30 years old and she's ready to start a family. Well, our young female physicians, that's one of the things that you got to go through, and it disrupts your patient care, but that's the reality. And so it's just, let's celebrate these life milestones, but it's just that challenge. And then some of you probably got Dr. Patel's letter. Paul Patel's retiring from the clinical practice in Madison. Well, good for him. Disrupts your care, but it's good for him. So we had 2 PCPs start in the month of October. I'm hoping to hire 3 to 4 more to start next summer. But trying to find enough PCPs to serve the people of this growing community is a challenge. Again, I was talking to Tom, and as he was exiting his practice, physicians are coming out of school now with somewhere $300,000 to $400,000 in debt. They've got a mortgage, but they don't have a house. Now, they have a very good way to earn a living, but it is a challenge for them. And so that's the attractiveness of a hospital employment contract or an organization like ours that give them an opportunity. They're not willing to come out and borrow another $200,000 to $300,000 to start a practice, to buy a building, all of those things. And then again, I'm getting into my macro side, but trying to get enough PCPs is a huge, huge challenge. Then, specialty physicians. again, you're looking at a situation where recruiting to Murfreesboro is pretty easy. If you think about it, those 25 people a day, right? If I can get them here, Rutherford County, Murfreesboro is a very attractive market for someone to come, set up a practice, move their family here. We get a lot of folks that are coming in, okay, what's their attraction to Middle Tennessee? Well, they visited Nashville and they really like it. That works some. But again, it's, if I can get them here, if we can show them what Murfreesboro and Rutherford County has to offer, and we can normally be successful. It's just finding them. Physicians are aging, and we're gonna have, we already have a nationwide shortage of physicians. And when they're aging and getting out, and then you couple that with, y'all may remember Jerry Campbell, retired pediatrician in town for many years. I think he practiced with MMC for 37 years. And he would see 80 patients a day. He would see them until they stopped coming. Well, that is long gone because people want to go have dinner with their families, put their kids to bed, read to their kids. I mean, things that maybe not being in a medical field you enjoy. My public accounting, I missed a lot of that as well. But that is the physicians that are coming out of training now, that they're not going to work and see patients till they quit coming every day. So just trying to find those docs, it's a real challenge for us in the community. There's some specialties right now. I think Gordon could nod along and say we need more of them in Rutherford County just to meet the needs of this population. Last one I would put on the micro side is just the ever increasing patient expectations. Right now, I was up at a tractor dealer yesterday and I said something about a code on my tractor, and he said, just put it in ChatGPT. And I tried, and I got a very extensive answer from ChatGPT. Now go to ChatGPT and put your medical system, your medical symptoms in. If you're a radiologist, AI is probably going to eliminate your job in the next several years. The AI computer-assisted diagnosis is typically much more accurate than a human radiologist looking at the films and the studies. And it's actually a rule now that on mammography, they have to use computer-assisted diagnostics before the physician radiologist looks at the film on those mammogram films. It's not films anymore, but you know what I'm talking about. Mammography. Larry was asking me questions about our phone system. Hey, it is hell to call MMC. And he's like, how am I going to fix it? I said, I can't hire enough people to staff the phones for the volume of calls we get. My goal is to make it where you don't have to call. What can you do online? What can you do electronically? We are using an AI receptionist now to where, what department do you want to speak to? Internal medicine, and it will transfer you to internal medicine. But there's things like that so we can process the calls. There's other computer systems that we're going to have to implement in the next 12 to 18 months that will allow us to allow you to do more online, to schedule appointments, things like that. But there's changes coming with that. But y'all have an expectation of you're going to be able to call and get an appointment with your physician. You're going to be able to talk to your physician. You're going to be able to talk to somebody. It is something. Also, when you come in, it's like I said with Dr. Google and Dr. ChatGPT, patients come in with a list of things that they think they have. And maybe they're right, maybe they're not. But that's what the doctors are having to overcome sometimes. It's like, well, Google said I had this. And then I'll tell you just a personal story. About 2 years ago, I was having some neck issues, and a doctor put me on a bunch of Advil. And so my primary care, my labs, my sodium is real low. And he, okay, let's test it again. I'll just tell you, I love fried foods. I love salt. I love anything southern, so just the more salt the better, right? It's like, there's no way my sodium's low. And I was like, well, what's an indication of low sodium? It's like, I'm not going to Google that because I don't want to know. And there's really bad things. You always heard about too much salt in your diet, too much sodium, but low sodium, I mean, pretty bad, Tom?
Very good.
It can be very bad. And so I finally Googled it, what causes low sodium, and it's all these things, and then it said a bunch of ibuprofen. It's like, I quit taking ibuprofen, dealing with my neck pain, but my sodium's good. So it's that Google, and you got everything figured out while you're there. So let's talk a little bit about the macro side, because this is, and I didn't put government regulation up here. That is a challenge, both at the state level and at the national level. The cost of care is exploding. You've heard all this stuff about affordability. You've seen the debates, I'm sure, about the subsidies for the Affordable Care Act premiums and what that's going to do. Why is the cost of care going up so much? A lot of it is what the plans are mandated through the Affordable Care Act to cover. If you think back, I say when I was a kid, we had indemnity plans that, tire rotations and oil changes aren't covered in your vehicle's maintenance plan. It's something you did your preventative maintenance, but then you had a catastrophic plan that covered surgeries or hospitalizations or things, the high cost stuff. Now the expectation, back to the other slide, is everything's going to be covered. You paid your premiums and maybe you have a copay. Patients are so insulated from the true cost of care now that you don't realize what it costs to provide this care. And so when you start looking at this, and I, as the CEO, I have the benefit of not just being the leader of an organization providing care, we're a consumer of care also. So we purchase insurance for our employees. And if you have not gone through that process as a business leader to know what that true cost of care is, you see it coming out of your paycheck potentially of $200 or $300 a month and all this kind of stuff. But when you start looking at the total claims that your company pays when you're a self-insured employer especially, and you start seeing the millions of dollars going to drug companies, GLP-1s, we don't even cover it for weight loss, but the cost of those is driving up the care, driving up the cost of care. Specialty pharmacy is a huge driver of insurance costs right now, healthcare costs. There's amazing things that they're doing with drugs, but when you see the millions of dollars that are going to that, even in a small plan like ours, just with, like I said, 900 employees, you think of some of the larger companies, how much more you're talking about. But nothing is being discussed about why costs are going up by government officials. They're just poking each other in the eyes and am not R2, and just arguing about how are we going to subsidize the cost of the insurance as opposed to really peeling back the layers of the onion and start trying to determine what's driving those costs and what can be done about it. That is, I think, the biggest thing on the healthcare front that is sitting out there. I mentioned earlier the looming physician shortage. We can't make them fast enough. We have not, I don't believe we've increased. Residency programs are set by the government, I believe. The number of residency slots for physicians exiting medical school and going and getting their training. And I don't think that's increased in a while. Even though the United States population has increased, since a lot of physicians want to go into specialties that are more lifestyle conducive, I think the highest demand specialty is a dermatology fellowship. They don't want to go in internal medicine like Tom. It's tough to make some money in those roles where if you're in a specialty like dermatology where you got a lot of cosmetics and other opportunities. And as I had a family doc say at a conference one time, there is no such thing as a dermatological emergency. If it's wet, dry it. If it's dry, wet it. That's my attempt at driving. But it is a real thing. There are not enough physicians in this country, and it's going to be a while before there are. Entrance into private equity into the physician world. So y'all may remember in the late 90s, MMC's physicians entered into an agreement with a physician practice management company. They basically sold the practice to a company called Ficor out of Nashville. It was a publicly traded entity that bought practices around the country, gave them a bunch of money, and then entered into a contract to lead their practice, manage their practice, and for a percentage of EBITDA. Well, what that means is unless there was some opportunity for revenue growth, physicians were taking a haircut on the pay. It was going down by 16%. Clinic got out of that in 2000 and has grown itself back. Now private equity is coming in, kind of the same model. They're giving the doctors a big check and they're gonna make it up somehow. I've had 2 physicians in the last 3 years ask me what is the likelihood MMC will sell to a private equity firm. Because it's great for the docs that get the money, but you can't recruit after that because if you're giving them 16%, 20%, 15%, whatever that percentage is, the new docs coming in, they didn't get the big check when the practice sold. But they're going to be making 15, 20% less, whatever that percentage that the private equity firm's taking. I'm going to get some popcorn and kind of sit down and watch how this falls apart because I know how the story's going to end. There was a situation in Middle Tennessee back this summer that you could not get an X-ray read in Nashville easily. And this isn't an indictment of Rotary Hospital, but my assistant had her dad there with a suspicion of pneumonia. And the ER doc or whatever said, we need to get a chest X-ray, but it'll be a week before we get it read. Because of the radiology private equity blow up that affected pretty much every hospital in Middle Tennessee. And I sit on a TMA committee and I had a Nashville primary care doc complaining about private equity. He said, you cannot get an X-ray read in Nashville. Right there. Yes, sir.
I'll confirm that. I know somebody who just got an MRI done and called the doctor. Is it red? Is it red? Is it red? He said no. He came back and he said, you got to understand this agency just got bought by private equity. First thing they did was reduce staff, and then they have more work to do, and they just kind of get to it when they can. And this was straight from the doctor. He's like, I can't control that. I just don't have the results.
It is a difficult situation that, again, I don't think it's necessarily good for medicine. There's some places for things like that, but it's a challenge at the national level. We probably have a couple private equity owned practices here in Murfreesboro and Rotary County. I'm not entirely familiar with all of them, but I would almost assure you that there are some practices that have been purchased and rolled up into private equity firms. And typically the model with that is they'll roll them up, sell them, and then somebody else will roll them up some more and sell them, and whoever's the last one holding the bag, turn out the lights or whatever you want to call it. But it is an issue. I talked earlier about fewer and fewer independent physicians. Why does that matter? Gordon may come up here and smack me around a little bit with this, but other than the gift shop and the cafeteria, a hospital cannot create $1 of revenue without an order signed by a physician. And so when you don't have independent physicians anymore, it is more and more of a challenge, I believe, for care to truly be independently delivered with patient focus. Gordon, and again, I don't want to sound like I'm talking bad about hospital employed physicians, because they do some amazing things. You know, I think of the hospitalist and what that type of specialty has done to enable other physicians to have a reasonable practice, while at the same time hospital admitted patients get better care from a hospitalist that's there all the time. So there's ways for both of this to work, but it's just the independence, the fewer and fewer independent physicians is just something about which I'm very passionate, and try to do everything I can to foster independent practices. Then the last one I put up here is the impact of artificial intelligence on medicine. If you don't use ChatGPT now, it's pretty cool. I don't pay for it, but I keep it on my phone and I'll type in a question and get a pretty good response. I mentioned my tractor code. Don't know if I know how to fix it, but they gave me a response. But it is getting into medicine now. So for instance, we have a computer system that will look at the physician's note that will then tell them, this is how you need to code that to bill it to the insurance company. The other side of that is Blue Cross, Cigna, United have AI platforms on their side that are looking at this bill that comes in and say, well, that's a 99215, that's a level 5 office visit. But, you know, Joey, it's just for a sore throat or a strep throat. That shouldn't be a level 5. But then what that doesn't do is look at the note that says, well, Joey has this, and he's on 6 other medicines that I also dealt with. And so then they're automatically down coding and paying physicians and hospitals and things less based on that AI framework. So it's there, it's coming into the diagnosis, it's coming into the treatment. It's scary. I was listening to a presentation last week, and there are AI programs that can break their way out of their boxes. If you think about this, it programs on some system and they build a firewall around it to self-contain that AI program. And it is self-preserving such that it can figure out a way to propagate itself on a different system outside of that box. And so, just watch that one. That's not just a healthcare, I guess that's everything else. Anyone have any questions?
I just have a statement.
Yes, ma'am.
My primary care doc is at NMC, and it took me a while, but one of the most convenient things I have found is the electronic
The portal?
way of messaging, yeah.
The portal? Yes, ma'am.
I need a new script, here's my flu shot, here's whatever. And usually within an hour or so, I've got a response. Which is great, instead of me staying on that phone for 15 minutes trying to tell them I need
a new script, or I need an appointment or something like that. That was my example, one of the examples about how can I reduce the number of calls coming in using our patient portal is one of those things.
I've had a great experience with the patient portal. So we live stream, so I won't be specific, but had a situation in my family where one person had a medical problem that resulted in me, it's a long story, but needing an antibiotic while I was sitting in the Vanderbilt ER with her. And it turns out a pediatric ER doctor is not going to prescribe a antibiotic to an adult, even though they're sitting there with the situation. So I messaged my primary care doctor at NMC and said, this is why I'm at the hospital, this is exactly what happened. The doctor here thinks I probably should get an antibiotic, and she called it in, and by the time we got home from Vanderbilt, it was waiting, there. So a good example of the portal, that it was an easy way. And honestly, I didn't want to sit at the phone, I wanted to be present with my daughter, and I just fired it off and it got taken care of. So.
And then you've got folks like my sister that can't make it work for her. I don't know how much technical resources
I do have a question about the portal. So if you're within MMC, right? So we have a couple different specialties within MMC, records are shared, labs are easy, all of that is great with inside MMC. But in reality is most people, I think, don't get everything done at one place. So maybe we have a doctor in a different system, whatever it is. So we have like, between our kids and us, we have like 3 different portals that we have to work through. Is there some push to, I don't know if it would be one portal, that probably doesn't make sense, but somehow standardize record sharing so that if my, neurologist is over here at this group, but my primary care is over here, it would be easier for records to be sent and shared?
If the other practice also uses the same portal software
Right.
that we do, then yeah, those records would be in that same
And
portal.
I've got a couple of those instances, but what about, another group that handles
Like you have
kids,
your
like-
standard medical record that follows you everywhere.
Right, yeah, exactly. Yes.
That interoperability has been talked about. There are some systems, now one that we are considering moving to, like I mentioned, in the next 12 to 18 months, is so broadly adopted that there may be more of that, just because again, if you're on that system,
Right.
any practice, any group, any hospital that also uses that system, all your records will be accessible and available to you through the portal or.
Because the other piece of it is, if I go, let's say I go to Mayo Clinic for some reason and MMC sends my records, well, they're probably going to send like a PDF. It might as well be a binder, right? If it's not the same system. So somebody has to integrate that into their system so that it's not just a record, it's actually in there to compare. So it seems like that is a challenge to get all that.
It
together.
is. Yes.
When I was growing up, you went to the doctor once a year and you got a checkup, and then you went when you needed something. But I remember, I'm old enough to remember when PPOs and HMOs started coming out, and I was over an office of a bunch of people, and some of the women started going. They went to the doctor more frequently because it was covered. And then, isn't that also driving up healthcare costs because we're actually using doctors more because we're...
Well, I would contend yes and no. If you're appropriately going when you appropriately need to be seen, then yeah, that's typically going to be actually lower cost. If you're hypochondriac and you got the sniffles and all this kind of stuff, but most healthcare professionals will tell you having a physician relationship, seeing that physician, primary care doc at least once a year, and having a good care plan, and then that preventative care, getting those labs, making sure you're following all that, will ultimately save money in the overall cost of care. But if you're going 3 or 4 times a year for any and everything, then maybe not. Yes, sir.
I'm hearing with a lot of interchangeable options of medical records. How are you handling HIPAA regulation?
Well, we can transfer records for care pretty easily without your authorization. So if you were to go, as Andrew said, to Mayo Clinic, we can send your records to Mayo Clinic to facilitate that without you having to authorize it. But once you have the providers are I'm forgetting the term, but we're bound by HIPAA, so we can share a lot of times between us and Rutherford Hospital, Vanderbilt, any of these others, or if we send them to TOA or something, we can send those records over there without any problem. Yes, sir.
What's MMC's outlook on the rural health care bill?
The one from
$50 billion, and each state has to opt into that.
well, the biggest bright spot I see on it is requiring states to get rid of CONs. That is something I've been fighting for about 20 years. I want to rip it out and stomp it flat.
I understand.
I'm a free market guy, and if you want to come in and start a physician office and you beat me and you're better than me, that's not on you, that's on me. So I don't believe in restricting competition, and so if that accelerates some things that we've already put in place at the state level to get rid of CONs, I think that helps. Medical care in rural communities is a challenge. I was saying I can get doctors to locate here. I don't know how one would react if I said, we're gonna put you in Woodbury or
I understand.
or Lynchburg or some of these others. But I'm in favor of a lot of things in it, but I'm still figuring out how the governor and the state's going to address it.
Last one is.
CON.
Yes, sir.
What's the CON?
It's called a certificate of need. Tennessee is one of a few remaining certificate of need states, to where if you want to provide certain healthcare services, you have to file an application with the state of Tennessee to get permission to implement those services. So I was talking about Vanderbilt earlier. They requested a CON to put a 50-bed hospital out off of 840, and it was awarded, and the hospital systems in the area contested that, and so it's been going back and forth legally for about, originally started in the summer of 2020, but I think where we are now, this case stems from probably December 21, something like that. But it is, you know, it used to be by law, if you wanted to put in an MRI, you had to get a CON. Now it's driven more by the population of a county. So since Rutherford County has over 250,000 people, we put a second MRI out at our West Lawn location 2 years ago without having to get a CON. It's an expensive process. It is a political process. It's so funny when you go to a hearing that you got these attorneys. That's their practice, is doing CON work. And they'll be up there arguing for something one time, and then the next item on the agenda, they're in opposition to, and every argument that they just made for whatever their project they're touting, they're making the same arguments against it for whatever it is. It is such a process, but getting rid of that, I think, would help maybe drive down some cost. The rural hospitals, I think, are ones that really fight it because they're worried that somebody comes in, puts in a surgery center, and takes all the attractive cases out of the hospital setting that the hospital makes money on. So that's kind of the whole situation behind it.
Thank you so much.